So to share with you our Hyper-CVAD experience, single institution trials, all phase 2s, no phase 3 studies. So what we have accomplished so far, TKI in combination with chemotherapy is standard of care for ALL pH positive, and it may move into what we call pH-like patient as well, more or less transplantation. Hyper-CVAD in Burkitt leukemia is well established. Rituximab has an added value, no questions. CNS prophylaxis, no radiation, just intrathecal, personalized based on risk factors, essentially 8 for standard risk, higher risk, and Burkitt 16. Recently, we had 2 drugs approved. Clofarabine, unfortunately, may get withdrawn from the market, but we'll see. Liposomal vincristine, another drug. And finally, today, we have the luxury of incorporating new agents into the Hyper-CVAD, or the backbone of the Hyper-CVAD regimens. So what used to be an optimal regimen is passed already. The BFM, the CLGB, the old Hyper-CVAD, the linker MRC, LALA 87, and therefore today, at least at our institution, this is what we have. Burkitt, Hyper-CVAD Rituximab times 8, 16 intrathecal cure rate approaching the 90%. For pH-positive ALL, Hyper-CVAD and TKI, today we have Ponatinib in combination with the Hyper-CVAD, transplant in CR1, although in patients who achieved an early complete molecular response, transplant is on hold, but that is not yet standard of care, cure rate approaching 50%. T-cell ALL, lots of chemotherapy, Neralabine into the model as well, cure rate 50 to 60%. CD20 positive ALL or pre-BALL depends on the age. Again, Hyper-CVAD, Rituximab, our backbone, cure rate 50%. For the young, for the adolescent and young adult, still the young because I'm not used to the adolescent. I don't treat adolescent anyway. So Augmented BFM or Hyper-CVAD, I will come back to that. That is my main talk. And finally, the MRD. You've heard the excellent talks of my colleagues this afternoon about MRD, how we're moving into the MRD, how we can save this patient by monoclonal antibodies transplant or new other innovative approaches. I want to start with the area where there are no controversies. And Dr. Felding is here. So combination of chemotherapy and TKI has completely changed the outcome of this patient. From a survival of 10% at 1 year or 2 years, today we can expect to have 50%. The question left are, okay, which TKI to be used? What is the best combination, sequential, concurrent, transplant, or no transplant? Here our experience with Hyper-CVAD and imatinib, standard Hyper-CVAD, clear difference favoring a combination of Hyper-CVAD and imatinib. Now, this experience has been observed as well in a pediatric population as well, where a concurrent combination of chemotherapy and TKI, especially imatinib here, does improve outcome, especially in patients who are placed on imatinib, infinitely starting up front and keeping them on imatinib. In fact, patients who had this combination at 1 year did do better than transplantation. Therefore, in young people with pH-positive ALL, we may get rid of transplant and its complications. My boss taught me transplant is like Catholic marriage. If you're miserable in it, you're miserable for life, you can divorce. You get transplant, you have GVHD, you cannot get rid of it. So, finally, Dr. Felding's paper published recently in Blood, highlighting the impact of imatinib on the outcome of this patient. Patients who did get imatinib did do better than those who did not get imatinib therapy. So TKI and chemotherapy is the key for this patient. Now, in her paper, transplant, in patients who had a transplant, imatinib did not really impact outcome, but the question was, how many of these patients did get imatinib for how long? So the devil in the detail, like how many patients did place on maintenance imatinib before and after. And here the Kaplan-Meier curves clearly favoring the imatinib era in combination of TKI. Now, you may say Hyper-CVAD is very aggressive, and can we try something less intensive? And then see if we have a good response early on, we may get rid of intensive chemotherapy and even transplant. This is the experience of Philippe Rousselot from France, where 71 patients, median age 69, received a very simplified regimen, essentially with dasatinib, vincristine, and steroid, and then consolidation followed by that. So he reported good responses, and in fact, patients who responded well and achieved the PCR negativity had a 3-year survival of 80%. But not everybody did get this level of response, and we did see relapses with the 315I mutation. So that is a problem with the TKI available, the second generation and first generation, where when they progress and relapse, they have the 315I mutation acquired. In our department, Dr. Ravandi led our experience using dasatinib as a second-gen TKI in combination with HyperCVAD. Median age is 55. We went up to 80. We had good responses. The problem with this trial, we did have deaths in CR. And the problem is when you go above 60 and HyperCVAD full dose and TKI and pleural effusion and others, we did lose some patients. And when they relapsed, they did relapse with the 315I mutation. 30% of these patients did acquire the 315I mutation, and we did see more CNS relapses. We are seeing around 30% of patients relapsing having CNS disease, which was not observed before. That led us to modifying our protocols and using 12 intrathecal instead of 6 and 8 in these patients because they live longer and they may relapse with CNS. So in view of this data, essentially, with the 359 mutation, with ponatinib being approved and being more potent than other TKIs, we modified our strategy and we combined HyperCVAD and ponatinib. Up front, we did 45 milligram of ponatinib for 2 weeks, and once you go into remission, you get ponatinib 45 milligram with the HyperCVAD for 8 cycles, then 2 years of maintenance with vincristine, steroid, and ponatinib, and then beyond that, ponatinib all the way. Now, this regimen was designed before we knew about the vascular events encountered with ponatinib. 36 patients treated and enrolled in this trial. Now we have 42 patients. I will come back to that. Responses were really good. Whether you assess by MRD, by flow, or by PCR, we have great responses approaching the 95%. And moreover, we had no single relapse in patients who were treated with this combination. We did lose 4 patients, 2 of them from vascular events. All the deaths we had, they died in CR. Essentially, 2 of them are vascular events. After the data of the vascular events and after what the FDA suspended the drug and closed our protocol, we had to modify our protocol. And today, we use 45 only for induction therapy and then 30 milligram later on till we hit CMR. And once we have CMR, we go down to 15. In fact, among the 36 patients enrolled, 2/3 of them did switch to other TKI, and we did not lose a single response. That means rather than taking the French way of going less intensive chemotherapy and then switch them to more intensive regimen later on, maybe starting with more intensive approach and de-escalate and maintain them with a lower approach when you have very low tumor burden. So that's what we have so far with the HyperCVAD in Ph-positive leukemia. Now, in Burkitt disease, we don't have much controversies. Hyperfractionated cyclophosphamide is the key treatment in this disease. HyperCVAD has performed very good. The addition of Rituximab to the HyperCVAD regimen has improved the outcome. And today, for Burkitt leukemias, we do 8 cycles of HyperCVAD and Rituximab with no maintenance, with 16 intrathecal chemotherapy, and we have a cure rate approaching 90%. And that is not only the experience of MD Anderson. Here, the German group, when they added Rituximab, they approach a cure rate of 90%. So for this patient, HyperCVAD Rituximab is our standard of care. Now, for patients with double hit, we're using the approach of dose-adjusted EPOCH in combination with Ofatumumab. I don't have data to share today. Here, the survival curve from the German group approaching 90% survival for patients treated with Rituximab in combination with chemotherapy. Now, I come to the topic where we have questions, the pre-BALL, HyperCVAD Rituximab. Just to remind people in the room, my colleagues, this is the backbone of the HyperCVAD as we use it today. 8 cycles of HyperCVAD alternating with methotrexate and cytarabine. Rituximab, 375 milligram per meter squared given 8 times for the first 4 courses. 8 intrathecal chemotherapy, 2.5 years of pump maintenance therapy, interrupted by 2 what we call early and late intensification, HyperCVAD 1 course, asparaginase, methotrexate during the second course. As Dr. Dewar mentioned, it's way much more simple to memorize than the Augmented BFM or the pediatric inspired regimen. I will come back to that. With that in mind, here are the results published by Debbie Thomas in JCO, where Rituximab did improve outcome of this patient expressing CD20, and the cutoff is 20%, mainly among young people. Above 60, we did not see an improvement. The 5-year survival of this patient is approaching 60% with the HyperCVAD Rituximab. Similarly, across the Atlantic in Germany, they reported their experience combining chemotherapy and Rituximab was found to be beneficial, improving the 5-year survival to 70%. Can we do better than that? Well, we tried. And then Ofatumumab is another humanized naked anti-CD20 approved for CLL. It has higher potency in binding to the CD20 and inhibiting the cells. Now, the cutoff for Rituximab is 10 to 20%. Here, with any expression 1% and above, patients do get Ofatumumab. The question we face, we give 2 grams of Ofatumumab, the labeled the approved dose, versus 375 for Rituximab. Are they equivalent? Most likely they're not. We don't know. Anyway, we know from a CLL experience, Dr. O'Brien published that there's clear dose-response relationship with the Rituximab. You escalate the dose, and you can obtain better responses. Is that applicable in ALL? It's unknown. Same backbone of the HyperCVAD plus Ofatumumab. Here the responses so far, early responses, we have around 35 patients enrolled, but here what we had initially, 96% responding. We had MRD at CR in a range of 60%. During consolidation overall, approaching 96%. Early deaths, we had only 1 patient. We have a follow-up of 18 months today, and here the survival and overall survival at 1 year in the 90% and above. Obviously, the follow-up is short, and we need for this data to mature and see really whether it will be maintained or not. Another topic, the T-cell ALL, HyperCVAD is our backbone for this patient. They come with mediastinal disease. They may benefit from radiation therapy. The question here in this treatment, Nelarabine. Where do we put Nelarabine? We tried in our experience to do 4 cycles of HyperCVAD and add Nelarabine later on and then rotate this chemotherapy. Still, we don't know if it's better than HyperCVAD alone or not. That is a question to be answered. Now, all these are HyperCVAD. We adjust our dose when you have 60 and above, where we reduce the dose of the cyclophosphamide, we reduce the dose of methotrexate, cytarabine, and anthracycline as well. But all these together, what is the myelosuppression observed? Time to recovery after induction therapy and during subsequent courses, 3 weeks. So we're able to get the chemotherapy delivered back-to-back every 3 to 4 weeks, at least among patients who are 60 years and younger. Now, from the HyperCVAD experience with 280 patients analyzed, how many did get their chemotherapy? The 8 cycles of HyperCVAD, 64%. The 8 cycles of HyperCVAD were given within 5.8 months, means 6 months of 8 cycles, means 21 days. The majority did get this chemotherapy. Now, a minority did receive fewer than 4 cycles, 16%, and mainly these patients are 60 years and older. Half of our patients who did not get the full 8 cycles were older than 60, and those who moved to pump maintenance therapy right away did move because essentially of myelosuppression and infections, deconditioning, they moved to maintenance therapy. Unfortunately, in patients who are older than 60, we did see the deaths in CR from essentially sepsis, 2 patient MDS, and other reasons. So here where we're standing with the HyperCVAD. Now the question that comes, well, in adolescent young adults, is it HyperCVAD or it's a pediatric inspired regimen? Here is a summary of outcome of adults and young adults treated with historical regimen where you can have a survival at 5 years going from 40 to 60%. Definitely my colleagues here did champion the pediatric regimens in these populations and compare them to the old regimen and concluded that these patients should be treated with the pediatric regimen. We improved the CR rate and the outcome with no increase in safety concern. Now, all these comparisons were essentially based on historical data, and the HyperCVAD was never compared to the pediatric regimen. So what is the cutoff? Where should we stand, and what shall we do? Here I want to share some experience that you're familiar with, essentially the French experience, where they tested a pediatric approach in patients up to age of 55. And they compared their data historically to the LALA-94. What they found is the pediatric regimen do improve CR rate, do improve survival. However, patients who are above 40 or 45 did not benefit from this approach. There was a high rate of morbidities, toxicities, with no difference in relapse rate. At the last ASH meeting, the UK ALL-14 was presented by Dr. Patel. They added the asparaginase to their backbone. Unfortunately, they reported 20% induction death, essentially from liver problems. These are the presentation at the last ASH meeting. And again, their conclusion was, well, this regimen do benefit most of the patients, 40 and above do not benefit from this approach, and that led them to modify their regimen for these patients. No, I thank Dr. Wendy Stock for her slide. You heard about it today from my colleagues about the US intergroup. They finished their accrual. They used the pediatric regimen in adolescents and young adults up to age of 39. 318 patients were enrolled. Again, for Dr. Dewar, it's so complicated to memorize this regimen. If I have a patient in the clinic, I have to call the research nurse, show me every note, go to the pharmacy and write it down. I understand why my colleagues in the community will like Hyper-CVAD, because they memorize it and they can write it very easily. But that being said, here are the results. Great results, 318 patients enrolled, and very successful. Now, of note, the median age is 25, although, as Dr. Advani mentioned this morning, it went up to 39. 25 is the median age, and only 14% were below the age of 20. The results were positive. There was no increase of the safety concern, and they reported a 2 years event-free survival of 66% and a survival rate of 78%. This data were presented by Dr. Stock in December in San Francisco. Now, just to go back to Dr. Nachman publication, in patients up to age of 21, the 5-year survival and longer is ranging 78%, but keep in mind, in a US intergroup trial, only 14% of these patients were up to age of 20, the rest were older than that. So with these findings, with these trials, we were under enormous pressure at MD Anderson to decide what to do for our patient. Do we go with the Hyper-CVAD or we go with the Augmented BFM? So 8 years, all infrastructure way dedicated to answer this question. So Dr. Reeting, who's pediatric oncologist at our institution, did lead the study where patients up to age of 40, regardless of their insurance, their status, whatever, they do get Augmented BFM regimen. And we need to have this experience prospectively and then compare to Hyper-CVAD and decide what to do next. These are the data that were presented at the last ASH meeting. We enrolled 116 patients. The paper is accepted in Cancer. It should come online very soon. So we had great results, CR rate, MRD negativity, but then when you compare CR duration and overall survival in similar patients, two prospective trials, Augmented BFM and Hyper-CVAD, retrospective comparison, 200 patients almost, there was no difference in outcome between the two trials. Here are the Kaplan-Meier curve for CR duration and overall survival with 116 patients enrolled. The 5-year CR duration is about 58%, and the 5-year survival, 62%. Now, how about age? How patients do perform by age? No difference in CR duration. Patients who are above 21 did benefit. Below 21 did benefit. The 5-year survival is 70%, while patients who are 21 and older, the 5-year survival is 58%. The Hyper-CVAD Rituximab is around 65% at 5 years for same patient population. And here are the Kaplan-Meier curves for all patients together, prospective trial, completely overlapping. No difference whatsoever. So in our department, when we saw this data, there was a big debate. Shall we keep going with the AYA program or move back to Hyper-CVAD? I won't hide that a lot of physicians were reluctant to the AYA, And Dr. Kantarji, my boss, was really, you need to do the AYA, we need to get the data out, we need to know whether the AYA program is better than Hyper-CVAD, and we completed the study. So no difference so far observed. So 21 and younger, they do great. However, the rest, they do not, is at least equivalent to Hyper-CVAD, if not, especially for those who are older than 25 and 30. Now, let's compare safety concern. I agree with the Hyper-CVAD is more myelosuppressive. We do see neutropenias, we do see growth factors, they go to the hospital. Infection rates, a little bit higher with Hyper-CVAD, 80% versus 70%, but we do see more increase of the bilirubin with the augmented BFM regimen. We do see pancreatitis that we do not see with the Hyper-CVAD regimen or very rarely, and thrombotic events. Avascular necrosis, no difference between the two regimens. In augmented BFM, we use prednisone. In Hyper-CVAD, dexamethasone, but essentially no difference. So we have more liver problems, we have more pancreatitis, and we have more thrombotic events. So similar efficacy. In our hands, safety, we can manage it. So we're more comfortable with Hyper-CVAD. Hyper-CVAD is, the augmented BFM is as equivalent as Hyper-CVAD regimen. Now, one thing we observe, and I don't know why, CNS relapses. So with the augmented BFM we used, we did not use the intensive chemotherapy like high-dose methotrexate or cytarabine that we use with Hyper-CVAD regimen. Intrathecal chemotherapy 15 to 18. We used prednisone, not dexamethasone. And we did have 10% CNS relapses. Of them, half of them are isolated. And this number is higher than what we observed with Hyper-CVAD. So is that due to our experience, to we don't manage the OMAIA or whatever, or it's due to the chemotherapy that crossed the barrier, like high-dose cytarabine or methotrexate? That is just an observation. I'm reporting it here. So finally, what are we doing at MD Anderson? Burkitt, Hyper-CVAD, Rituximab, lots of intrathecal chemotherapy, pH-positive ALL, Hyper-CVAD and Ponatinib, and maintenance with Ponatinib therapy. Transplant only in patients who are 0.1% and above in CR1. In patients who are CD20 positive, Ofatumumab and Hyper-CVAD. For those who are 25 years and younger, AYA program above 25 years, based on the data I showed, we do Hyper-CVAD, Ofatumumab, and then we're trying to incorporate the new agent into our Hyper-CVAD, and we're trying to minimize the Hyper-CVAD. Instead of giving 8 cycles of chemotherapy, maybe give 4, and use monoclonal to complete the treatment and less maintenance therapy. So thank you for this opportunity. I believe that ALL, the cure for ALL is here. In my lifetime, I'm 40, I'm not 50. I'm optimistic. The cure is happening, and time will tell. Thank you very much.